Welcome to the deep dive. Today we are cutting through the noise on a topic that feels like one of the highest stakes decisions a junior doctor can face. We're talking about assessing capacity.
It really is. It's the one that sends a lot of MSRA candidates into a cold sweat because it sits right at that intersection of, clinical urgency and some pretty dense legal complexity.
Exactly. So let's just anchor our dive with a classic dilemma. Imagine you're an A&E. You've got a patient, they're clearly delirious, hypoxic, and they're refusing urgent life-saving IV antibiotics.
Mm-hmm.
Clinically, you know they need the treatment right now. But legally, you have to respect their refusal if they have capacity. So our mission today is to turn that high-pressure, time-critical mess into a clear, structured, lawful pathway. We're going to make sure you know the highest scoring steps from the Mental Capacity Act, the MCA.
And if we can boil the entire MCA down to just one high-yield idea for the exam, this is the core truth you need to remember. The SJT rewards doctors who first support decision-making, then apply the two-stage test for this decision right now, and only if capacity is lacking, follow a proportionate, documented best interest process using the least restrictive option.
That sequence: support, assess, decide, document. That's your safety net. So why does this one topic get so much focus, both on the ward and in the exam?
Because it's non-negotiable and it's highly testable. Clinically, making these decisions lawfully is what protects a patient's autonomy while also making sure they get safe care. It protects you from accusations of battery or negligence.
And for the MSRA, it's a really high-frequency topic, isn't it? It's directly anchored in the GMC's good medical practice.
It is. And what's really interesting about the scoring pattern is that the biggest trap is rushing to paternalism. What feels like the most clinically sensible option.
Right, just giving the treatment.
Exactly. High scores come from resisting that urge and actually demonstrating the support before assessment principle. The law forces you to maximize autonomy before you can declare it missing.
Okay, let's unpack the legal skeleton that guides all this. The MCA is built on 5 foundational principles. And these aren't just legal jargon, are they? They're the mindset you have to adopt.
They absolutely are. They define the entire framework. So 1, you assume capacity until it's proven otherwise. That's always your starting point.
Always.
2, you must support decision-making. So you do everything practicable to help the patient decide for themselves.
And number 3 is the one that I think catches people out.
It is. An unwise choice does not equal incapacity. People are allowed to make decisions that we, as doctors, might completely disagree with.
Okay, and 4 and 5.
If capacity is lacking, you must act in their best interest. And that action must always be the least restrictive option to get the job done.
So that sequence is the foundation.
Yeah.
But how do we actually prove incapacity? That's where the two-stage test comes in, the legal gatekeepers.
This is what you must document every single time. It's exactly what it sounds like, a test in 2 stages.
And stage 1 is the medical hurdle, right?
Correct. Stage 1 is the diagnostic bit. Is there an impairment or disturbance of mind or brain that's causing the problem? We call it the diagnostic nexus.
So you're thinking of things like acute delirium, a stroke, maybe psychosis.
Exactly. Hypoxic brain injury, severe learning disability, intoxication. If the patient is completely compos mentis, no impairment, well, then capacity is assumed. You stop there.
That makes sense. But what if the patient clearly has delirium, like our hypoxic patient from A&E? They pass stage 1. So that takes us to stage 2, the functional test, which feels like the trickier part.
This is where the real nuance comes in. Stage 2 checks if the impairment from stage 1 is stopping the patient from doing one or more of the 4 functional abilities needed for this specific decision right now.
And the failure has to be because of the impairment.
That's the key. So let's break down those 4 abilities because the SJT gets very specific here. The first one.
First is the ability to understand the relevant information.
Yeah. Can they actually absorb the risks, the benefits, the alternatives of what you're proposing? And your job, under Principle 2, is to simplify that information first. Make it understandable.
Okay, so understand is number 1. And number 2?
To retain the information long enough to make a decision. This often trips up patients with, say, acute delirium or short-term memory loss. They might get what you're saying 1 minute, but forget it the next before they can actually form a decision.
Right. Now, the third one, I think, is often the trickiest clinically. To use or weigh the information. How do we test that?
This is a high scoring point because it separates an unwise choice from true incapacity. A patient fails the weighing test if they can list the risks and benefits, but they can't actually connect them to the decision.
Give you an example.
Sure. A patient might say, I understand refusing this amputation means I could die, but then immediately say, But I need to go home and feed my cat, so the risk doesn't matter. They aren't integrating that consequence into their calculation.
So they can see the words, but the meaning isn't landing.
Precisely. If they weigh it up and still choose the outcome you disagree with, that's a lawful, unwise choice. But if they literally cannot weigh it, that points to incapacity.
That distinction is just vital. It's about the process, not the outcome. And the fourth ability is communication.
Yes. To communicate their decision, and that's by any means. Speech, writing, blinking, a communication board. You have to exhaust every option. An inability to speak is not the same as an inability to decide.
So the crucial thing to remember here is that capacity must be decision-specific and time-specific. You can't just label someone as having no capacity.
Never. Now that we have the legal test, we need the high-yield pathway. The SJT scores you on taking the right chronological actions in a crisis.
Okay, let's map that out. A 5-step framework. What is the mandatory first action?
Step 1. Support understanding. This is absolutely mandatory. It must be the first step. Before you even think about declaring capacity missing, you have to maximize it.
So what does that mean in practice?
It means optimizing their physiology. So treat their pain, give them oxygen, find a quiet space, get an interpreter if you need one. You eliminate the reversible causes of their confusion first.
Okay, so with our hypoxic patient A&E, before we even test their capacity for the antibiotics, the first step is making sure they have oxygen, maybe treating any pain or low blood sugar that could be causing the delirium.
Exactly. Remove the obstacles. Then, step 2, apply the 2-stage test. Establish the impairment for stage 1, then systematically test the 4 functional abilities for stage 2 for that specific decision, and you have to document why they failed.
And if they fail, that's when we move into the sphere of best interests.
Yes. Step 3. Decide best interest. And this is a structured process, not just a gut feeling. You have to follow the MCA Section 4 checklist. So that means consulting family, friends, anyone who knows the patient's past wishes and feelings. And you also check for 2 things that come up a lot in the exam.
ADRTs and LPAs.
Exactly. An ADRT is an advanced decision to refuse treatment. It's a legally binding document made when they were competent. If it's valid and applicable, you have to follow it.
And an LPA?
A lasting power of attorney. That's someone legally appointed to make health decisions for the patient. Their word essentially stands in for the patients.
What if there's no family, no friends, no LPA, but the decision is really serious?
That triggers the mandatory referral for an IMCA, an independent mental capacity advocate. An IMCA is required by law for serious medical treatment, like major surgery or accommodation changes if the patient lacks capacity and has no one suitable to consult.
Okay, that's step 3. What's step 4?
Step 4 is choose the least restrictive option. It's right there in Principle 5. If there are 2 options that achieve the same goal, you must choose the one that interferes least with the patient's rights and freedom.
Can you give us a quick example of least restrictive?
Of course. Say your delirious patient keeps pulling out their IV line. The most restrictive option is physical restraint or heavy sedation. The least restrictive option might be moving them to a quieter room, using verbal reassurance and distraction, maybe even just covering the line with a bandage so they don't see it. You have to start with the least restrictive and only escalate if it fails, documenting why.
And finally, step 5.
Step 5. Document and review. Record everything, the support you gave, the findings for all 4 ability, who you consulted, the rationale for your best interest decision, and crucially, a review plan. Capacity can change, so you must reassess it regularly.
To make that whole process stick under exam pressure, let's use a mnemonic.
Yeah.
You've got one for us.
I do. Think SCALE, S-C-A-L-E.
Okay, scale. Let's break it down. S.
S is for support understanding. That's step 1.
Right. C must be?
C is check for impairment. That's stage 1 of the test.
Okay.
A is apply the 4 abilities. Stage 2.
Go.
L is for least restrictive best interest. That's steps 3 and 4 combined.
And E, the most important bit for passing exams and staying safe.
E is for evidence in the notes. Document and review.
So when you hit an SJT scenario, you can almost visualize this as a decision tree. You start at the trunk, which is support, go through the gate of the 2-stage test, and only if they fail do you go down the lawful branches.
Exactly. The worst thing you can do is jump branches. So let's connect SCALE to some classic exam setups.
Okay, pattern 1, the refusal of risky, urgent treatment, our hypoxic patient.
What's being tested here is balancing that clinical urgency against the legal process. The best action. First, stabilize them, oxygen, pain relief. Then assess capacity immediately. If they lack capacity and a delay would cause serious harm, you can proceed with the least restrictive treatment in their best interests and the antibiotics while you formalize the process.
Right. What about pattern 2, the unwise decision? For example, a patient refusing a really necessary amputation.
The test here is principle 3. Unwise does not mean incapable. The best action is a scrupulous capacity assessment. Pay really close attention to their ability to weigh the information. If they have an impairment, but can fully understand and accept the risk of refusal, their decision must be respected. Your discomfort doesn't matter.
And pattern 3, the communication barrier, like someone with severe aphasia after a stroke.
This is testing your duty to maximize capacity. Principle 2. The best action is to prioritize communication aids, interpreters, a quiet space, everything you can think of before you test capacity. The low-scoring doctor assumes they can't decide just because they can't speak.
The high-scoring doctor facilitates communication first. And the last one, pattern 4. No family or friends available for a serious decision.
This tests the correct use of the IMCA. If the patient lacks capacity for a major decision surgery, long-term treatment, a move to a care home, you must instruct an IMCA. It's a crucial legal safeguard.
Okay, looking at the big picture, these actions score well because they show structured thinking, not personal bias. Let's flip it and talk about the common decoys, the things that will instantly drop your score.
Trap 1. Assuming an unwise choice means no capacity. That's the most common failure. It violates principle 3. Capacity is about how a decision is made, not what the decision is.
Trap 2. Skip support, just test quickly. Big mistake. If you skip optimizing the patient first, you violate principle 2. You might wrongly decide someone's incapable when they were just temporarily confused by pain or hypoxia.
Trap 3. Using global labels. Writing no capacity for anything because of a diagnosis like dementia, you must test for the specific decision they face right now.
And trap 4. Thinking best interest just means whatever the doctor prefers.
Yes. This ignores the whole legal process of consultation and choosing the least restrictive option. Best interest is a structured process, not a clinical whim.
Finally, trap 5. Delaying urgent care.
This is so important. While assessment is crucial, you can't delay life-saving treatment if harm is imminent. The law allows you to treat urgently under best interests as long as you document the urgency and formalize the assessment straight after.
Perfect. To really seal this in, let's do a quick rapid-fire drill. Short, sharp knowledge bites.
Okay. If a patient is drowsy from an opioid overdose and refuses a life-critical CT scan,
Optimize their physiology. First, give oxygen. Consider reversing the opioid if it's safe, and then apply the two-stage test specifically for that scan decision.
great. If a patient with stable, mild learning difficulties refuses discharge from hospital,
You'd ensure you use simple language and aids, assess capacity for that decision. If they lack it, you follow the best interest process, consulting their family or carer, and document why discharge is the right plan.
perfect. If a patient with schizophrenia refuses an antipsychotic injection, but they show they fully understand the risks of stopping it,
You have to respect that lawful refusal. You document your thorough capacity assessment, that you discussed the risks, and that they passed all 4 functional abilities, even if you think it's an unwise decision.
what's the one thing you must not do if a patient lacks capacity for serious treatment and has no family?
Do not forget to instruct an IMCA. It's a mandatory legal safeguard in that exact scenario. This has been a really dense but really necessary deep dive. Let's just distill the 3 core learnings you need to carry into that exam.
Okay. 1. Always remember the mandate. Support, then assess. Maximizing their autonomy is the mandatory first step. Never jump to best interests. 2. Capacity is defined by the 4 abilities for this decision now. Make sure your thinking and your notes reflect that specificity and really focus on their ability to weigh the information.
And the final point.
3. If capacity is lacking, commit to the least restrictive option. Consult widely, using that Section 4 checklist, whether it's family or an IMCA, and document your full reasoning.
I think the ultimate insight here is that the safest doctor is the one who prioritizes a clear process and detailed documentation. It turns what feels like a scary, ethical decision into a structured, lawful pathway.
Absolutely. Mastering the Mental Capacity Act structure is mastering one of the highest yield topics on the MSRA SJT. Just keep that scale mnemonic and the decision tree visual in your mind. Process equals high scores.
Keep pushing with your learning. You will pass the MSRA. And for more resources like this, you can always check out PassTheMSRA.com.